Hi, I'm Dr. Flores, and I'll be presenting my research titled The Cushion Effect Revisited, which is basically a retrospective chart review to examine how obesity affects MBC-related injury patterns. I came to the Valley to begin my general surgery residency about 4 years ago, almost to the date. During my second year, I completed a 3-month rotation of emergency and trauma medicine. Now that I think back, one patient always really stood out in my mind. The patient was a 43-year-old Hispanic male, BMI of 56, who was involved in a head-on MBC going 45 miles per hour. His only complaint at the time was vague abdominal pain. The reason it really stayed with me is because it really challenged my bias. Here I was a young doctor, and after examining my patient, I felt that there was no way that he suffered an intra-abdominal injury given all his extra cushion. However, my attending physician, in all his wisdom, disagreed, and we ordered a CT scan. We found a significant bowel injury, and this patient ended up going to surgery. This is a valuable experience, and it really highlighted to me a real issue of particular importance to the Rio Grande Valley, which is the interplay between automobile accidents and a uniquely at-risk population. The Rio Grande Valley population is unique in many aspects. It is significantly younger, more obese, and Hispanic than the rest of the United States. The median age of Hidalgo County, for example, is 29 years old, making it the second youngest county in the entire state of Texas. 40% of adults are obese, 92% are Hispanic, and the median household income is almost $20,000 below the national average. Why are these things relevant? Well, as it turns out, every single one of these things mentioned are risk factors of not only being involved in an MBC, but of worse outcomes. The link between obesity and worse outcomes in trauma and critical care literature is very well studied. It's multifactorial, it's semi-intuitive, and it's related to many things, including increased pulmonary complications from mechanical ventilation, increased infections, and increase in all-cause mortality. Less intuitive and more interesting to me as a frontline provider was how do we appropriately triage these patients? Do we need every CT scan every time? Does obesity influence the pattern of injury significantly at all? While researching this, I found a landmark paper aptly titled The Cushion Effect, which is a retrospective chart review of 189 motor vehicle accidents or crashes, MVCs, to study the influence of SEPA use, velocity, type of impact, and obesity on mortality in organ-specific injury severity score or ISS. They found that with increasing BMI, there's increased all-cause mortality, increased risk of injury to lower extremities, and decreased abdominal injury severity score, but not risk of injury, as well as no sexual differences. This seemed to kind of confirm my bias, so maybe I was right after all, and the patient previously had enough cushion to protect them. But as I looked further into the matter, the results weren't cohesive at all. For example, another very similar study done around that time in obese children noted that they had an increased risk of intra-abdominal injuries with increasing BMI. So, what was the consensus? The answer is that there is none. Overall, it appears that obesity tends to be protective for head and neck injuries and exacerbating for extremity injuries, with little to no modification in abdominal or thoracic injuries. But honestly, I question how attributable these studies were to a radically high-risk population, and I set out to complete our own study. We launched our investigation in 2019. Essentially, we queried the STRAC, or South Texas Regional Trauma Council database for all NBC CPT codes between 2014 and 2018. Basically, it gave us a list of all the NBCs um, that had happened that went to those hospitals associated with the South Texas Regional Trauma Council for those years. We filtered for an ISS greater than 8, um, just because that was associated with an increased risk of staying in the hospital. So there were significant accidents and adult individuals between 15 to 64. We also excluded all motorcycles and ATVs because the mechanics of those accidents are much different than the mechanics of an average automobile accident. We ended up with 191 individual accidents. We automatically imported age, sex, BMI, or race from the charts, and we manually categorized each injury that the patient had suffered. So we combed the chart. We found, for example, that this patient had a head laceration. So we would check yes for head and neck injury. For example, multiple rib fractures. So yes, chest injury, abdomen and pelvis, and extremity injuries. Basically, all of them had predetermined injuries that we agreed as a trauma program that they were going to be considered head and neck, chest, abdomen, and pelvis injuries. If we had any questions about whether an injury was to a particular organ system or significant, we had two attending physicians that oversaw the project, as well as me, the primary investigator, and another resident that helped us comb the charts. Once we had combed the charts, Our data was analyzed by an experienced team of statisticians who essentially performed logistic regressions on the four coded injury types: head and neck, chest, abdomen, and pelvis, and extremity, with our clinically relevant variables being sex, age, presence of a seatbelt, speed, and BMI. These were treated as independent variables, but also any significant interaction amongst them was examined. Long story short, our statisticians were able to examine if there was any significant interactions between our clinical variables individually or with each other for odds of injury in these four organ systems. We found that in our population there was no significant interaction between our variables and odds of receiving an intra-abdominal or thoracic injury. We did find that there was an age-related protective effect for intra-abdominal injury. We found that there was an increased odds of extremity injury with increasing BMI. And we also found that there was significant sexual difference for odds of head and neck injury with increasing BMI and male sex leading to a higher number of head and neck injuries, and increasing BMI and female sex leading to a decreased odd of head and neck injuries. Overall, our study seemed to coincide with the current literature, but there are some unique aspects. Um, in our study, there does seem to again be a trend for increased extremity injuries with increasing BMI and MBCs. Most papers cite an overall reduction in head and neck injuries with increasing BMI. However, in our paper, it seems BMI interacted with sex to create a protective effect in females and an exacerbating effect in males. Um, Age extremes in the literature seem to be a factor for all-cause mortality in MBCs, and also with an increased risk of rib fractures in the elderly. But in our current finding, they caused a reduction in intra-abdominal injuries. Um, and so this is relatively new and hasn't really been studied before. We believe that most of the things in our study can be attributed to sexual deposition of fat and its variation with age. We know that fatty tissue growth and distribution is influenced by age, with a predisposition for visceral and truncal fat in males and subcutaneous and lower body fat in females. But the differences don't only stop there. A comparison of obese male and female airways using MRI technology showed a couple interesting findings. One was that females had a statistically significant increase in deposition of subcutaneous fat, and that fat was primarily infrapalatal, so below the jaw, with increasing BMI compared to males. So, so perhaps there may be sort of a cervical collar effect that isn't evident in males. Another possibility as to why males with increasing BMI tend to get more head and neck injuries has been posited, mostly due to the higher center of balance, or higher center of mass rather, that males have compared to females, leading to a more moment deceleration in an MBC to the head and neck and upper extremities in males than females. When the car decelerates, the greatest force is exerted on the center of mass, and in males it's higher, which could create more shearing effect in the head and neck. Are finding that with increasing BMI, the odds ratio for extremity injury increases is also commonly found in the literature. Many mechanisms have been posited. Most focus on the fact that each extremity has a higher momentum effect due to the increase in mass, and the other is that due to the design of the vehicles, an obese person is more in contact with hard surfaces. The most common example is obese females tend to have a greatly increased chance of receiving a lower extremity injury, namely due to dashboards. And then as far as our age-related finding of increasing age leading to a protective effect on intra-abdominal injuries, we believe that this is also explainable due to sexual distribution and age-related changes of the deposition of fat. Many studies have found that as males increase in age, they get an increase in subcutaneous fat, especially if they already have truncal fat, then they're going to get increased subcutaneous truncal fat. Females tend to have an increase in truncal fat, and they're already predisposed to have subcutaneous distribution. So overall, it seems like there's a equalization effect on both of the two body phenotypes, which with age seems to kind of make them both develop more truncal subcutaneous fat, which is one of the few morphologic findings in the literature that have been shown to reduce risk for intra-abdominal injury. So kind of tying it all together, Hispanics seem to have lower levels of sex hormone binding globulin, as well as a predisposition for a younger age of menarche and also a younger age of menopause. The reason for these effects remains unclear, but it could possibly be due to also higher prevalence of obesity in Hispanic children, triggering puberty at an earlier age. The reason it's relevant is because, as we discussed, the sexual distribution of fat could possibly lead to an exacerbation or protective effects for certain injuries, um, and our population, especially Hispanic-heavy populations, may suffer from an exaggerated version of that. Uh, our takeaway point is basically that each person and patient is an individual and needs to be treated as such. We cannot assume common sense things are true, um, and we also cannot assume that research applies to all populations the same. We believe our research can be used to expand the body of knowledge in this topic, as well as frame arguments for reduction in healthcare costs by increasing effectiveness and reducing wastefulness of imaging, and also by shedding light on motor vehicle design. As far as I know, the latest models for the crash test dummies are still 5'7" and 170 pounds, which may not accurately reflect our changing demographics. Um, Thank you.